Remote patient monitoring applied to diabetes care has evolved significantly over the last 10 to 15 years, right? Back in the day, the significance of having the glucometer data available to care teams when you're in the doctor's office face to face required a physical connection where you brought in your meters, the nurse would take it, connect it to the computers, download the data, so they would get the last several months of information to review with the patients on site face to face. And the evolution of that system kind of evolved as technology changed that allowed then for Bluetooth-enabled devices to connect with local devices that patients had, phones, tablets, etc., to make that transmission more closer to the time that patients could benefit from modifying their therapy. So instead of waiting for 3-4 months to review this information, patients could have this information available to their care teams to work with them between the doctor's visits. So that type of connectivity has more significantly changed with the advent of continuous glucose monitoring, where this now information could be made easier to collect and closer to the actual actions that patients could take with this information. So that now enables remote care teams to intervene more immediately and sooner to help manage their patients' ability to manage their medications, also improve their behaviors and diet, etc. So over time, the capability of remotely collecting this data and more importantly now embedding it into your clinical workflow has helped to drive better outcomes for patients and their health systems and care teams. When implemented correctly, so one of the challenges with these remote patient programs is to make sure you're addressing equity appropriately. So making sure you have the right program, devices, connectivity issues resolved so that you are now able to achieve those outcomes. So it's when appropriately designed and implemented. So it's not just collecting the data, but building a program around how to act on the data, how to engage patients. And then ultimately, when tracked over time, the goal is to, for example, track measures such as A1C, so you can actually, successful programs are able to achieve significant reduction in A1C levels for their patients while improving lifestyle behavior change elements as well. Really straightforward. The three key takeaways are make sure that your programs that you're building are able to engage patients where they are and in a way that allows you to serve diverse patient populations. So once this data is collected, it's got to be available and embedded into the clinical workflow for doctors and nurses and the care teams to be able to act on this. And then to engage patients in a way that helps drive the best outcomes achievable, either through mobile interaction, phone calls, video calls, in a way to support and engage the patients to achieve their goals in a way that you don't have to wait for them to come in and see you like they used to do in the past. There's several key challenges that systems face when trying to implement these type of programs, right? In the past, traditionally, it had to do a lot with getting buy-in from clinicians to understand how to use this information, especially at a time when it was not being reimbursed, right? Traditional healthcare models required you to be in front of a patient to help with their needs, evaluate them, assess what the needs were, modify the care plan. And so that was reimbursable when you were face to face. So one of the big challenges that a lot of systems have to overcome is how do you build a scalable, economically viable, cost-neutral programs? And you can now do that by combination of value-based care models as well as designing fee-for-service models that are driven to achieve the best impact and outcome for patients. So as long as you're designing with those core principles, you'll get buy-in from your care team, compliance with your patients, and you'll get the the system outcomes that you need. So one of the barriers for adoption has always been how does this become an economically viable program while also achieving the clinical outcomes and measures that are needed to maintain the quality for my organization. The second is making sure that you're not adding any extra burden for your care teams to reduce the clicks or the views needed to review this information as it's coming in. especially now with new modes of continuous data available, having access to relevant information in a way that's summarized accurately and allows you to use that information without overwhelming the care teams with the quantity of data coming in really helps to reduce those barriers of clinical buy-in. And then ultimately for the patients to know that there is a support available either asynchronously or synchronously when patients need help, knowing that there is a support infrastructure that's going to be engaging with them between the inpatient visits. So those are the kind of the three components of us to help overcome barriers to adoption.